Congenital cardiac defects are abnormalities of the heart or the great vessels which are present at birth. These usually occur due to a defect during the embryogenesis process early in development, that is during the 3 to 8 weeks. The etiologies mainly include environmental factors such as rubella, teratogens, and maternal diabetes, and also some genetic factors, for example, in trisomies 13, 15, 18, and 21, and also Turner syndrome. Now, we can classify these defects on the basis of a criteria, that is, if they cause a left to right shunt, if they cause a right to left shunt, or if they cause obstruction of vessels. First of all, we're going to see the left to right shunts. Now, one thing to remember about them is that they're the most common congenital heart disorders. They do not usually cause cyanosis, but their main complication is going to be Eisenmenger syndrome. This is actually a reversal of shunt when the left to right shunt is then over time converted into a right to left shunt. So let's talk about this first. Now, don't get scared of this slide. It is very busy, I know, but we're going to get through it. The first congenital heart defect to understand is patent foramen ovale. Now, to understand this, let's see some embryology. This here is the development of the septum between the two atria. So this is the septum primum, which is beginning to develop between the two atria. Then as it reaches here, this becomes the septum primum and this becomes the septum secundum. Then we have another septum that grows like this. So normally this is the foramen ovale. So this is the right atrium and this is the left atrium. So normally in the fetal life, blood will flow like this and this will be no problem. But after birth, when the pressures on the left side of the heart rise, they are going to push these flaps against each other and they will fuse, and there will be no more connection between the right atrium and the left atrium. But in this case, in the case of patent foramen ovale, the flap is of adequate size, but it is not sealed. So we can see here that these flaps are of adequate size, they cover each other. It's not like there's a hole, but the flaps do approximate, but they have not joined. Okay, so I want you to distinguish between a patent foramen ovale and a atrial septal defect. Now in atrial septal defect, what happens is that there is going to be a permanent hole here. Okay, so till 1, 2 and 3 the development is normal, but here I've shown a atrial septal defect. So in this case you can clearly see that this hole is permanent. Okay, and there is always going to be mixing of the blood between the right atrium and the left atrium. But in this case you can see that even though these flaps have not been joined, but still, because right atrium has lower pressures, what happens is, and left atrium has higher pressures, this will cause this to remain closed. Okay, so we do not generally have many symptoms in this case. This only occurs when the right atrial pressures in some cases rise due to increased venous return due to certain positions such as squatting, etc. So there will only be transient blood flow from right to left. Okay, both of these are left to right shunts, because here also the hole is in the atria, and because pressures here are increased, blood should go like that, but that usually does not happen. What can happen is that when right atrial pressures increase, there can be transient flow of blood from right to left. So I hope that is clear. Patent foramen ovale do not have any complications as such, but this can manifest usually as a paradoxical emboli. We know that usually there is deep venous thrombosis in the legs, and venous thrombosis, whenever it dislodges into emboli, what will happen is that first of all they'll come to the right atrium. Right now, technically they should go into the right ventricle and then into the pulmonary circulation. So usually the DVTs go into the pulmonary circulation. But in this case, what happens is that since we have this right to left shunt transiently, not always, but when right atrial pressures rise, then there is a chance of paradoxical embolism. That is, this emboli will go from the veins into the right atrium, and then to the left atrium, and then through the left ventricle to the systemic circulation. So this embolism will not be going towards the pulmonary circulation but towards the systemic circulation, which is not a usual case. So that's why it is called paradoxical embolism. I hope that is clear. Now, in atrial septal defects, as I said, is that there is an abnormal fixed opening between the atrial septums. Okay. Now, the ostium primum defects are 5%, which are associated with Down syndrome, while majority of them are ostium secundum defects. Okay. And in some cases, there are also sinus venosus defects in 5% of the cases. In this case, we're going to have unrestricted blood flow between the two atria. Okay. Okay, so regarding the clinical features, these are usually asymptomatic till adulthood. Now we have a left to right shunt, right? So we know that left heart has greater pressures, so we're going to have blood going from the left atrium to the right atrium and then into the right ventricle, and this flow of blood is going to cause volume overload in the right atria and the right ventricle. So we are going to have S2 splitting. S2 is as we know that it is due to pulmonary valve and aortic valve closure. In this case, what happens is that there is delayed pulmonary valve closure because the volume has increased because of this shunting. So that's why we're going to have splitting of this heart sound. These defects are usually well tolerated initially, but can over time worsen because of all this shunting. When we have this shunting towards the right side of the heart and into the pulmonary circulation, we can develop pulmonary hypertension. So and pulmonary hypertension is then going to cause right ventricular hypertrophy and eventual reversal of shunt as well in some cases, but that does not really happen with atrial septal defects. Secondly, we have ventricular septal defects. These are most common congenital cardiac defects. Okay, the size and location of the defect will vary widely. Now, in case of large defects, what happens is that, of course, it is a left to right shunt, so the blood will be pumped from the left side of the heart into the right side. The right side of the heart will be congested, and due to volume overload, that will cause right ventricular hypertrophy, dilation, pulmonary artery diameter will be increased. This will cause pulmonary hypertension, vascular changes, etc. Regarding the clinical features, they may be asymptomatic. These defects can close spontaneously as well, and as I said before, the reversal of shunt is more common in VSDs than ASDs. And also, if these defects are smaller, and mostly they occur on the top of the septum, where the area is membranous and not that muscular, what happens is that they are going to form jet lesions. That is, if we have a small opening, they are going to form jet-like blood flow, and when this jet of blood is going to hit the right ventricle, that is going to increase the risk for endocarditis because of damage to the endocardium. The next disorder is patent ductus arteriosus. It is associated with congenital rubella. This is a point to remember. Now, before birth, what happens is that the right ventricle pumps blood into the pulmonary trunk, and the pulmonary trunk through the ductus arteriosus pumps this blood into the aorta, because we do not need to pump blood into the lungs which have not inflated yet. But after birth, what happens is that due to increased oxygen tension and decreased pulmonary vascular resistance and decreased prostaglandin E2, the ductus arteriosus closes on its own, and we have the normal adult blood flow. But if we have a patent ductus arteriosus after birth, that is, the ductus arteriosus has not closed due to hypoxia, then what happens is that we have another type of circulation. That is, this right atrium will pump blood into the right ventricle, into the pulmonary trunk, and since aorta has higher pressures, this will shunt blood from the aorta into the pulmonary trunk, and thus into the pulmonary arteries and into the lungs. So this is also a left to right shunt. Okay, this is actually a high pressure left to right shunt. It is going to produce machinery like murmurs. Okay, now these PDAs can be small or large. Small are mainly asymptomatic, but larger PDAs can lead to Eisenmenger syndrome, that is eventual reversal of the shunt, and also increased risk for infective endocarditis. The treatment in this case is indomethacin, which will decrease prostaglandin E2, and also surgical intervention will be necessary for permanent cure if that does not work. So, as a recap, during left to right shunts, we do not have cyanosis usually. The biggest threat is Eisenmenger syndrome, which is most common in patent ductus arteriosus, common in ventricular septal defects, and not that common in these two cases. Okay, so that is all about left to right shunts. Now let's see some right to left shunts. Now, one thing to remember in this case is that the main symptom here will be early cyanosis, and that will be shown by clubbing of fingertips and toe tips, polycythemia because RBC's number will be increased because the body will think that there is not enough RBCs, that's why there is cyanosis, and paradoxical embolization. As I said before, that venous thrombi that develop mostly in the legs, they will come to the right side of the heart, of course, and then they should have gone to the lungs and get stuck there. But in right to left shunts, they might go from the right to left side of the heart and then into the systemic circulation, and thus get stuck somewhere else in the systemic circulation. So that is called paradoxical embolization. So these are the main symptoms of right to left shunts. The first disorder is tetralogy of Fallot. Now, this is 5% of all congenital heart diseases and most common cyanotic congenital heart disease. So, if you see cyanosis, that is shortly after birth, the most common cause for that is this disease. Now, why does this occur? To understand the cause of this, we need to know that there is an infundibular septum between the developing pulmonary trunk and the aorta. So in this case, what happens is that there is anterosuperior displacement of that septum. So when that occurs, this is going to change into this. You can see here that the aorta has become bigger and the pulmonary artery has become stenosed, right? And also the aorta has overridden the septum. There is also a ventricular septal defect formation, and since we have pulmonary artery stenosis, thus we are going to have right ventricular hypertrophy. So that are the four features of this disease: pulmonary stenosis, overriding aorta, ventricular septal defect, and right ventricular hypertrophy. Now with that aside, let's see what clinical features we're going to see. The hemodynamic disturbances in this case occur because of the right to left shunt. Now you might say that this is a simple VSD, right? And in VSDs we've seen that we have usually a left to right shunt. But in this case we have a right to left shunt because here you can see that the pulmonary artery is stenosed and right ventricle has undergone hypertrophy. So the pressures now on the right side are higher than those on the left side. So we have a right to left shunt. There is also decreased pulmonary blood flow, which will cause symptoms, and increased aortic volumes that will cause the hemodynamic disturbances. So these three are the causes of the hemodynamic disturbances that we're going to see. The clinical features in this case are going to depend on the degree of pulmonary trunk stenosis. That simply means that if the stenosis is not that severe and blood can be pumped into the lungs, then the right side of the heart will not have that much pressure and the right to left shunt will not be there in the first place, and it will resemble isolated VSD because the right ventricle has not undergone hypertrophy, it is not having increased pressures, so there is no right to left shunt. If we consider a normal ventricular septal defect, then we have greater pressures on the left side, and then that will be a left to right shunt if there is a mild degree of pulmonary stenosis. One other thing to remember is that although in this case we have right ventricular hypertrophy, and we've seen that whenever that happens, just as in left to right shunts, there is severe complications of pulmonary hypertension. But in this case, what will happen is that this pulmonary orifice stenosis is going to protect the lung from that volume overload, and thus no pulmonary hypertension develops in this case, although the right ventricular hypertrophy is there. Now, regarding some sequelae or complications of this disorder, we have cyanotic signs, as I've mentioned before. There is also increased risk for infective endocarditis, and this is usually common in diseases when we see septal defects in which there is high pressure on one side and low pressure on the other side, and blood gushes through small orifices and hits the walls of the heart. So, that is potentially a cause of infective endocarditis, because there is damage to the heart walls, and then any bacteria or foreign agent can come along and cause inflammation there. So that is one problem. And secondly, we can have systemic embolization. Of course, this is a right to left shunt, so the embolus can pass from the right side of the heart to the left side and thus into the systemic circulation. Now, one thing to remember about this anatomical setting is that if the pulmonary trunk is severely stenosed, that is, it is completely obstructed, and there is no way that the right ventricle can pump blood into the pulmonary trunk, what will happen is that there is only this ventricular septal defect that will cause right ventricle to pump blood into the left ventricle and thus into the aorta. And this PDA, if there is a persistent ductus arteriosus, now this will be protective in this case, because that is the only way that this blood, this deoxygenated blood, which cannot be pumped into the lungs via here, can go to the lungs by using this path. So a PDA will be the only supply to the lungs, only way to supply blood to the lungs if the right ventricular outflow is completely obstructed. Okay, and one diagnostic sign for this disease is boot-shaped heart on X-ray. The second right to left shunt is transposition of great artery. That means both the great arteries, the aorta and the pulmonary arteries, have changed their positions. That is, the pulmonary artery arises from the left ventricle and the aorta rises from the right ventricle. So if that happens, then you can see that, let's see, the aorta is arising from the right ventricle, right? So it will go to the body tissues, then come back through the venous circulation and go to the right atrium. So this is an independent circuit, and similarly the left ventricle pumping blood into the pulmonary artery and then going back through the pulmonary veins into the left atrium, that will be an independent circuit as well. So both the pulmonary and systemic circuits will not mix. This condition is not compatible with life unless there is a VSD or a patent foramen ovale or PDA present, because these are the defects. If we have a defect here or between the pulmonary artery and the aorta, so these will be the only ways that blood can be mixed and can sustain life. Now, one thing we know, that this condition is not compatible with life, but if we have a VSD, that can sustain life and it can deliver oxygenated blood to the aorta. So if we have a VSD, what will happen? Right ventricular hypertrophy will be there, because this in this case is functioning as the systemic ventricle. You can see here that the right ventricle is connected to the systemic circulation. So the right ventricle will act as the systemic ventricle and it will undergo hypertrophy, and the left ventricle has no such load on it, so it is going to undergo hypoplasty. Now the clinical features, of course, they will be there when the patient is alive and there is a ventricular septal defect. So this will depend on the magnitude of the shunting, and there can be different clinical features. They also depend on the degree of tissue hypoxia and the ability of the right ventricle to maintain the systemic pressures. Now, most patients with transposition of great arteries die during the first few months if they do not undergo surgery. And lastly, the third type of congenital heart defects are obstructive lesions. We can have pulmonary valve stenosis, aortic valve stenosis, or complete atresia, and coarctation of aorta. Now, there is two types of coarctation of aorta. First is the infantile form, which is preductal, and the other is adult form, which is postductal. We call it ductal, but there is no PDA in this case. Okay, infantile form or the preductal form is often associated with the patent ductus arteriosus, but in this case, the coarctation, the constriction of the aorta, will lie distal to the aortic arch, to this, but before the PDA. Okay, so this is something you need to remember. Now, if we see this diagram, we can see that this is the aortic arch, the brachiocephalic trunk, the right one, there is one, and the left common carotid and the left subclavian have already arisen from the arch of the aorta, and then we have the constriction. So the head and the upper limb region will not be affected by this disease, but the lower extremities will suffer the most, and it is usually associated with lower extremity cyanosis in infants at birth. It is usually associated with Turner syndrome. Okay. The second form is the adult form of the coarctation of aorta. It is also known as postductal, although it is not associated with a PDA. This is just to show a difference between the infantile and the adult form. This is the ligamentum arteriosum. Okay, this is not the ductus arteriosus. This is usually associated with a bicuspid aortic valve. This is also a genetic abnormality. Now, what happens is that in this case, the coarctation is also distal to the aortic arch. Now, there is a mechanism called collateral circulation, in which what happens is that the post-stenotic descending aorta, this part, is going to receive blood from branches of the subclavian artery and axillary arteries via the intercostal arteries. So, intercostal arteries are going to go and feed this part of the descending aorta. Now, we know that the intercostal arteries are present along the ribs, and this has a characteristic sign on X-ray that is called rib notching. So, this is a characteristic diagnostic sign of the adult form of coarctation of aorta. Similarly, it is going to cause hypertension in the upper extremities and hypotension in the lower extremities. That's all about coarctation of aorta. Now, let's see tricuspid atresia. Now, in this case, we have complete blockage of the tricuspid valve, and the right ventricle is hypoplastic. Now, this is usually associated with an atrial septal defect because, of course, for this fetus to be born, there has to be a right to left channel through which the normal fetal circulation goes. But we do not need the right ventricle during the fetal life, right? But as soon as this baby is born and we need the lungs to function, that will not occur, and there is no passage from the right ventricle to the lungs, so this will present as early cyanosis. And lastly, we have the truncus arteriosus that fails to divide into the aorta and the pulmonary trunk, and there is a single large artery that arises from the right ventricle and the left ventricle. Okay, so this will also present as early cyanosis because the deoxygenated blood from here and the oxygenated blood from here are going to mix as soon as they get out of the respective ventricles. So that is the last of the congenital disorders, and that's it.